Okay, pain generation. So, we have dedicated nerve endings that permeate the body. Some of these are raw nerve endings with no attached receptors, as we saw earlier. Others have nociceptor attachments, thermal receptors, and chemical receptors, and these are specifically designed to register tissue injury by chemical pressure or temperature injuries. Of course, it originates here, comes through the dorsal root ganglion, remember in the spine, goes up and across the spine and then up the spinothalamic pathway. Why are these names important? Because it tells you where it comes from and where it goes to. And the thalamus is going to be a big issue for pain. So why do we need pain? I mean, what's the point of it? Well, there are patients born with congenital insensitivity to pain. When I was in Detroit, I saw these quite often for some reason. It's a genetic problem. They're patient born without pain feedback to their brain. Their spinothalamic tracts are underformed. So these people commonly lose fingers and toes through burns and compressive injuries due to a lack of sensitivity. They can't tell if their sock is too tight. They can't tell if their shoe is too tight. They can't tell if they put a wristband on and it's digging in, and they get injuries and they can't tell. So do we need pain receptors? Well, obviously we do. And then here's a good example. This person doesn't have a pain receptor because he's a paraplegic or quadriplegic, has no sensation below C7. But yet he has pain in his back because of the Charcot joint. And again, we were talking about if you have a spinal cord injury and you can't transmit that pain signal, how does it get up there? Well, we think there's some kind of abnormal connection between the sympathetic or parasympathetic nervous system and the somatic nervous system, and that also has to do with something called complex regional pain syndrome, or CRPS or RSD, but we'll again talk about that a little later. So, sclerotomal pain. This is one that's commonly misdiagnosed. So pain can be generated by distant but neurologically unconnected structures. It's known as referred pain. And these are not a direct result of nerve pain radiating down to its distribution. You have an L5 nerve root compressed, pain into the front of the toe. That's not sclerotomal pain, that's radicular pain. But patients will come in, and their problem in this case, for example, is an L5S1 spondylolisthesis, and they have localized pain, but it refers up. Does the L5S1 vertebra refer up? It really doesn't. But because their pain signals become overwhelmed, there's crossover stimulation in the spinal cord. Remember, the pain comes across and then goes up the cord, and we think there's a feedback mechanism that causes increased pain that's generalized. So you have to be careful when you look at this, because somebody comes in with one area, it looks like their entire back is involved. Some people will be interpreted as, that person's crazy. They don't know what they're talking about. But if you ask them carefully, they're receiving regions, sclerotomal, okay. Is it, wait a minute, next slide? Yep, okay. So what we did is we tried to figure out how this occurred. So we took medical students who will do anything for money. And we took hypertonic saline solution, so high concentration salt water, and we injected it into their facets. These are people who've never had pain. And this is the pain pattern they developed. So the L5S1 facet, you can see the pain radiates to the groin, down to the lateral hip, and around the buttocks. Well, that doesn't make any sense. The facet doesn't cause that. But this is sclerotomal pain. The facet was so inflamed by this injection of miserable water, they're questioning whether the $200 was worth it, of course. But we learned something. We learned that you have referral pains in a non-dermatomal fashion. So, the way to diagnose this is it's normally with severe excruciating lumbar pain caused by a degenerative disc or facet. Non-radicular pain may refer into the buttocks or thighs, and the pain will not be present independently. So somebody comes in, they say, I got terrible back pain, but my buttocks and thighs are on fire. Simply ask them, do you have the buttocks and thigh pain without the presence of lower back pain? They'll always say no. The back pain has to be there. Once it becomes so magnified, it starts to radiate. So sclerotomal pain is a differential diagnosis you need to know about, so you're not looking for other causes. Like, I'd look at this and go, boy, that could be hip, could be facet, could be nerve coming out through here, could be L1 or L2. But if you ask the question, there's severe localized pain first in the lumbar spine, and then this pain occurs, that's going to be sclerotomal pain. Important differential. There is bone injury pain. This is some of the worst miserable pain, other than the radicular pain where they have a fresh herniation and their nerve is on fire. That's probably the worst. But bone injury pain, if you look here, you can see the inflammatory changes within the vertebral bodies because the disc isn't doing its job. Every time you load the spine, you're getting end plate fractures and trabecular fractures into the bone. So this is localized depending upon side, but it's miserably dull, achy, painful, wakes them up at night. It's associated with what I call PFILP. It's a favorite term around our office, is it pay for it later pain. These are people who go out in the garden, and they're digging and they're hoeing and they're raking, and that night they can't sleep. They're miserable. Because of what? What causes delayed onset pain? The inflammatory cascade. So these are people who have an injury to arachidonic acid in the cell, and it has to go through the cyclooxygenase and lipotrypsin pathways before it becomes inflamed. That takes anywhere between 6 and 12 hours. So people with delayed onset pain typically have this kind of bone pain. So there's muscle-generated overload pain that's also burning and aching, similar to that bone pain. But this is increased intensity with activities that overloads the muscle. So if somebody's got an increased kyphosis, they're walking around like this and they're using their muscles to pull themselves back, and that muscle is chronically contracted, what's going to happen? Huh? Well, it hurts. Why? Because what's happening to the muscle? Lactic acidosis, right? So it's an anaerobic contraction. You're building up lactic acid and it starts to burn. And they're looking for a place to sit down or to lie down or do something, and the pain goes away, surprisingly, because you're not overloading the muscle. So you have to be careful when you diagnose things. Like, you want to look for inactivity with flat back syndrome, overloading the gluteal muscles, hyperkyphosis, increasing the extensor muscles of the back, forward head position causing extensor muscles of the neck. It'll be localized muscle pain. So, how do we know or figure out how these things occurred? How did we figure out the sources of low back and leg pain? Well, it all starts with William Röntgen. He finally gave us a window into the spine. We can take an X-ray and see what's going on. And this is back in 1895. But it only allowed knowledge of bony structures and nothing else. But it was at least the first window. Then we had a cascade of events. Yeoman in Lancet came up with the term piriformis syndrome, and I'm going to harp on this because I can't tell you how many patients I see in the office with a previous diagnosis of piriformis syndrome. Do you know why Yeoman did that paper? Well, people were showing up with significant leg pain, and it happens just like you see in your offices. People have leg pain. And so they didn't know anything about the discs and the nerves and all that, but they did do diagnosis by dissection. So Yeoman dissected out the piriformis and found that 10% of the time, the sciatic nerve ran around or through the piriformis. And since 10% of people had leg pain, aha, it fits. Nice paper. Totally wrong. Totally wrong. But piriformis syndrome continues to today. As far as a diagnosis, I've been doing this for 35 years. I've seen 2 cases in 35 years. So it's unusual to see it. Walter Dandy, whose son lives out here and has developed the CADs. Anybody remember those? Those little things in the back of your legs that you see people on the ski hill? Okay, anyways, that was his son, interestingly enough. But Walter Dandy did an experimental exploratory surgery on the spine of 2 patients with severe leg pain and found this substance in the canal. And you'd think it'd be a eureka moment, but he thought it was a tumor. So unfortunately, it took Mixter and Barr in 1934 to write the first disc herniation paper. We didn't know about disc herniations until 1934. So all this that we're talking about today is relatively new science. And then if you go back, you had pantopaque myelography in the 1940s. But you guys, if anybody remembers the problems with pantopaque myelography, it's oil-based dye. You have to inject it into the spinal canal, and then you have to suck it out. Yeah, it was terrible. But what would happen is a lot of patients would get arachnoiditis, which we'll talk about later. Finally, the CT scan by Hounsfield in 1971 and the MRI in 1977. So we're a really young science right now. We don't have a lot of things to look back on. So how did we make the connection between the lower back and the causes of pain? Smith and Wright in the 1960s, fascinating thing, would never be allowed today. They would do the surgery and they would take care of the herniation, then they would attach sutures to every structure in the spine and let the sutures hang out of the incision and close the incision. When the patient was awake, they would tug on each suture. So it's crazy, but that's what they would do. And we got a lot of information. So nylon sutures tied it on various important structures. Structures were labeled, left long and protruded. So you'd see this nylon thing, you'd have a little tag, Duramater. So they actually put a suture through the dura. I mean, I'm thinking, oh my God, you got to be kidding. But no, they did. And they pulled on the dura, and surprise, they didn't get a leak, I guess, but the dura was insensitive. Muscle, tendon, and ligament, generally no pain. Tension on the nerve root, leg pain. Tension on the posterior disc, back pain. So at least we're starting to get some connection. Then we have Kuslich out of Minnesota in the 1990s. He had awake but sedated patients. There are still some surgeons who keep patients awake today. It's an interesting story. But this guy would do his microdiscectomies on sedated patients. So what he would do is he would have the patient in position and he would numb up the skin with some lidocaine and then incise the skin and then get down to the fascia. And then the patient's awake, stimulate the fascia. Do you feel pain? And then he would numb the fascia, cut it, pull it away, get to the muscle, and then stimulate the muscle. Pain. And he would do that going down to the lamina, the ligamentum flavum, the dura, the nerve root, and the disc. And these patients would tell him what's going on. And so very similar to Smith and Wright's study, he would find stimulation of muscle, tendon, or ligament never produced back pain. Facets, rare lower back pain cause, but remember the facets he was stimulating were probably normal. This was a herniated disc, so there are some issues here. Normal, non-inflamed nerve root never caused leg pain, but would cause paresthesias. Now, why he would be looking at a normal, non-inflamed nerve root is a question we can't answer. But we still have the information, and that is that you take a normal, non-inflamed root, it won't cause pain, it'll only cause numbness. Just like resting your arm on a counter, your hand gets paresthetic but doesn't get painful, right? Same thing. An inflamed nerve causes exact reproduction of leg pain. That makes sense. If low back pain was present, stimulation of the disc would reproduce back pain. Well, it gives us some information about the posterior annulus and posterior longitudinal ligament. Disc and nerve stimulation at the same time, buttocks or sacroiliac pain. So now we're starting to put together what causes pain and to try and figure out how this all fits. So why can't patients come into my office and say, Doc, it's my left L5S1 facet. I'm sure of it. There's no question. They come in and say, I got back pain and nothing more. And why is that? It's because how we're wired. By the way, if you guys don't know Frank Netter, you've got to go back and look at his artistry. He has some of the best pictures to decide and determine anatomy there is. So this is Frank's idea of the homunculus of the brain, meaning how much surface area is any one area allotted to. So if you look at the tongue, let's call it 1.5 inches of dedicated space just for the tongue. There's less than that for the entire lumbar spine. So the reason you can't tell me it's your L4-5 root or it's your posterior longitudinal ligament, you're not wired to be able to tell us that. You're wired to only tell us you have back pain. That's why we have to do all the hoops and all the machinations that we do to try and figure out what's going on, because this, you can't tell me what's wrong. We can try and figure it out, and we have ways to do that, but that's what the science of this is. So, the spinothalamic tract, as we talked about, it starts down in the spine, right? Okay, and it goes up through the midbrain into the thalamus. And its output is important because this is pain output. So it doesn't just go to the cerebral cortex where you say, ow, my back hurts. It goes to the hippocampus. So you have feedback for memory. So you remember the incident that occurred that caused the pain. It goes to the amygdala where it gives you an emotion, a flavoring of the pain. It goes to the basal ganglia. We're still not sure why that does. Cerebellum is reaction time. Get your stupid hand off the hot irons, and the prefrontal cortex. So pain is not just wrapped in as a sensation. It's an emotion. It's a memory. It creates anxiety. It creates depression. So this is why we have so much trouble treating it. It is not a simple feedback mechanism like touch. So what happens with pain magnification? We see that with a lot of patients. They come in, this is a big problem. So why do some people hurt more than others? First is facilitation. It's the ability of a synapse to conduct more easily the more it is used. So the pain transmits easier the next time, leading to a chronic pain syndrome. It's just like a path of water. If water goes down a creek, the next time it's going to go down the same path. Same thing, pain is going to go down that path the same time and make it easier and easier. And the more pain you have, the easier it is to go down that path the next time. Then there's sensitization. This is important. Some cells in the dorsal horn learn not only to respond to the pain stimulus, but also develop an alerting signal that precedes a noxious stimulus. So here's an issue. This is where anxiety comes from, because you are already prepared to have pain for the next time, right? You're preparing for that. And your cells, unfortunately, create the problem. And then psychologically, the temporal lobe provides comparison of stored memories from previous painful experiences, leading to apprehension, and that leads to anxiety, depression. So it's not uncommon for patients that have chronic pain to have reactive depression. For some reason, it reduces the amount of serotonin in the brain, and people get depressed, and the cycle continues. And we'll talk about that. So, this is the bugger, arachidonic acid. So you have tissue injury, and the tissue injury allows translation to arachidonic acid, and it goes down two pathways, the leukotriene pathway and the prostaglandin pathway. And both pathways lead to sensitization of the nerve ending, okay? So leukotrienes cause chemotaxis of PMN, so polymorphonucleosides are drawn into an area where you have arachidonic acid. They degranulate, they have all sorts of ugly things inside their cell bodies, and it leads to hypersensitivity of nociceptors. The lipooxygenase creates the leukotrienes right here. Cyclooxygenase on this side causes prostaglandin formation. What's important is what is blocked on each side and how you use these medications appropriately. So if you use aspirin and nonsteroidals, it blocks this pathway right here, but does not block this pathway. So it only works on half of the components of inflammation. Steroids, corticosteroids, block the pathway that produces arachidonic acid, so it blocks both pathways. So steroids are great for what they are. And we'll talk about when you can use them and when you shouldn't. So you can also have hyperalgesia, meaning that you have increased pain response. You can sensitize the nerves so that they are easier to transmit next time. That's facilitation, but you can have sensitization where they trigger without signal. and that's hyperalgesia. You just touch the skin and it hurts. And we won't go through the whole pathways, but there are plenty of chemical pathways that cause that. Questions? We're dealing with pain right now, like trying to listen to this lecture and not fall asleep. Okay?
So you said something, you mentioned crazy people and...
Not crazy, no. I didn't say crazy people. It can make you crazy.
Anyway, I'm sorting out psychological components.
Yes.
Yeah, I'm curious about your, if you have an algorithm.
People can be driven crazy by pain. There are people who have incapacity to deal with pain. I mean, I've seen people in the ER walking in with their index finger in their other hand holding it saying, I need to have this reattached, and looking as calm as you are right now. And I have people with a big splinter come into the ER and I've got to put them under IV Demerol or morphine to be able to get the splinter out. So sensitivity is partially genetic. That's part of it. Sensitization can occur in normal people, but you can make an argument they had a genetic predisposition to have that problem. So you take them as you see them and as you get them, and you have to deal with them the best you can. And so we'll talk about ways to deal with all this. Right now we're talking about how and why it happens. We'll then talk, probably more likely tomorrow, about what to do with them.
Yeah, and I raised that question because 25 years ago in the Bay Area, our whites group, they had an algorithm where and it wasn't that they wouldn't do surgery on people with psychological factors, but they usually would triage them down and have them decide that.
Well, there are people that are not psychologically impaired until they get pain, and if you take care of their pain, they improve dramatically. But the problem is you can't easily predict who's who. So that's the biggest issue, is how do you select out the ones that can benefit and the ones that can't? And again, we'll talk about that when we get more toward the surgical side. Okay.
Can I ask you a question?
You can ask away.
So that an acute disc bulge or acute annular is going to release a bunch of inflammatory mediators and cause pain. But the neovascularization that caused by a chronic, I guess, a poor attempt to heal
Yes.
a tear, that what do you have you been doing to those things?
I can tell you what's been done in the past. There's a procedure called an IDET. I don't know if anybody's heard of this. It's an old procedure where you take a nichrome type wire and you percutaneously fish it into the disc, and it surrounds the inside of the annulus, and this wire heats up and supposedly coagulates the disc and was supposed to kill the nociceptors. It didn't work. It just created further degeneration. That's one of the techniques. There's a newer technique, theoretically, that can work, where you burn the input into the disc itself, and that's the complex. We'll see more anatomy slides of it. The basivertebral vein, which is in the smack dead center of the vertebra body, is where the venous outflow occurs, but thoughts are that that's a lot of innervation, and there are some experimental techniques to try and cauterize those nerves, like a radiofrequency ablation, to try and reduce the amount of nociception. There are other ways you can do it. Steroids work very nicely, and there are ways that you can mechanically take care of it, but once you become sensitized, it's hard to reverse, sort of put the genie back in the bottle. And this is, if you can come up with an answer, you'll walk in Sweden and they'll put that gold medal around your neck. Other questions? Okay, let's move on. Oh, please.
So if NSAIDs only stop half that chemical reaction,
Yes.
then what happened to everybody in the steroid is it stops right at the acid?
Well, because then you get ulcers, you get avascular necrosis, you get premature heart disease.
I'm saying in the acute setting.
Oh, in the acute setting?
Yeah, just like
Yeah, it makes a lot of sense.
dose pack.
It makes a lot of sense. And we don't use dose packs, we use Decadron, and we'll talk about the differences. But yes, if you come in, the first thing, if you're miserable, you're bent over, and you look like crap, you're going to get a steroid as your first technique.
For that reason.
Yes, for that reason. No other questions? Okay.